Good evening, ladies and gentlemen, and welcome to tonight's Wound Care Today Facebook Live. Thank you for joining us. The title of tonight's event is From First Aid to Prevention of Recurrence, Implementing the National Wound Care Strategy Programme's Lower Limb Recommendation. And our amazing speaker tonight is Dr. Leanne Atkin. Good evening, Leanne.
Good evening.
How are you?
I'm very well indeed, thank you. I hope you are too.
I'm very good. It's pouring with rain here. I had to run from the car. I've had a bit of a shocker, so if my hair is slightly wet, I do apologise. Ladies and gentlemen, as you can see, Leanne is presenting from home tonight. So if we have any technological problems, please bear with us and we'll get them sorted as soon as possible. The event will be available on our Facebook Live platform forever, but you can also download our slides, watch the video from the Wound Care Today website, which is woundcare-today.com. The link for your certificate of attendance will be made available towards the end of tonight's event, and this event will count towards your revalidation portfolio. Please get involved tonight, make comments, ask questions. I know Leanne will appreciate that. The more involved you are, the better the event will be, and we'll endeavour to answer as many questions as possible before the end of tonight's event. There are two massive things I need to do before we start. One's just a big thank you to Lohmann Rauscher. Without your support of independent education like this, these events simply could not and would not happen. So huge thank you. I've seen you involved with the latest Legs Matter document, which I've written down here, Making Legs Matter. I think it looks blooming brilliant. So, thank you for the support of that. I know Leanne was involved with that. That education is so important. And secondly, to our audience listening tonight, we haven't done a live event at Wound Care Today since February 2019, and we're back. October the 19th and 20th, Milton Keynes. The event's 2 days, it's free. Come to one or both days. I know how much work the team's put into the program, which I'm incredibly proud of. So please go to our website. There should be something up in the comments page now. If not, it's woundcare-today.com and register. I know myself and hopefully Leanne would look forward to seeing you at the event. So without further ado, it gives me great pleasure to introduce you to tonight's speaker. Over to you, Leanne.
Thank you so much for the warm welcome. Good evening all. And I'd just like to echo my thanks to Wound Care Today and also for L&R for sponsoring this session. I especially want to thank L&R because actually, please note that during this presentation, there's very little actually relating to their products in terms of compression or wound care. Actually, L&R are very committed to providing generic education, and that's why I'm so pleased to be here this evening. So this session is talking about really from first aid to prevention of recurrence using the National Wound Care Strategy lower limb recommendations. Please remember that please post questions, and we've got some time at the end of this for some questions, and it's horrible just to be asked questions by Ed. I'd much rather be asking your questions out there. So I think that really, whenever we're talking about lower limbs, we have to remember and start with really the burden of wounds study. So you are aware that back in 2015, the first burden of wounds study was published by Julian Guest et al. And actually a second updated version was published at the beginning of 2020. And the issue that we have is actually, it paints a very bad picture. Things have deteriorated significantly from 2012 to 2017-18. And when I say deteriorated, the number of wounds that we are treating across the NHS has increased, the cost to the NHS is increased, and actually the number of clinicians that's involved and our cost in terms of time has also increased. And for me, the most worrying statistic out of all of this is the number of chronic wounds that's out there has actually risen from 43% to 49%, with leg ulceration being the most prevalent type of wound across the UK. So in fact, I think the burden of wound study tells us that we're getting worse at this rather than better. So there is a huge need for change. It continues to be a humongous spend for the overall NHS. This graph that's being shown now still surprises me to this day. When you look at the cost of the NHS in terms of the wound care and the treatment of those patients with their wounds and their comorbidities. It's up there in the top spend across the NHS. Who would have thought really that the treatment of wounds and patients with wounds is up there really, not too far behind the treatment of cancer. And this is costs in terms of billions of pounds per year. This is not an insignificant cost. And across the nation, we have some terrible statistics that's presented out there. At the moment, we're spending around £3.1 billion on the treatment of leg ulceration. Around 1 million patients right here, right now, are affected by a lower limb ulcer. And that equates to about 2% of the adult population. And actually, there are some really shocking statistics in terms of you can have recurrence of a venous leg ulcer of around 69% after only 12 months of healing. And when you think about that, if we're getting 70% of venous leg ulcers recurring within a 12-month period, you can really ask yourself, what's the point of healing them in the first place? And we really have to shift our culture, our beliefs with the treatment of lower leg ulceration to really question, why do we believe a leg ulcer is not going to heal instantly? We should all be questing for the healing goal. This has been around now in terms of the need for change across the wider NHS for a long, long time. It started off, if you can remember, with Betty's story. And if you haven't watched this for a while, I urge you all, because it's under the badge of the right care, right time. And never has there anything been truer with a patient with a venous leg ulcer. And this video highlights really the care that the majority of patients across the UK still experience, where the wound on the leg is not recognised as a lower limb ulcer, therefore just treated with topical dressings without that compression. That patients really suffer in terms of their quality of life, their mobility, their overall suffering. And actually, if we were to get it right first time, we could actually save the NHS significant amounts of money. In fact, getting it right first time costs around 10 times less than the care that we are currently providing our patients. Within the NHS, we often hear about cost improvement programmes. And actually, if you ask me what that means as a nurse, I often think that you're going to downgrade some of my staff, you're going to take a bed out of my unit, or you're going to actually reduce the number of staff that we've got. All of that doesn't feel right as a clinical nurse. But actually, in terms of leg ulceration, this is a cost improvement programme that we can all get behind. Because yes, it's reducing NHS spend, but it's reducing our time as clinicians in terms of the treatments of these wounds and the burden to us, and it is improving patients' quality of life. So why on earth would we not implement this type of quality improvement programme in terms of getting it right first time? So really, if you think about things, we really need different thinking is needed in order to improve healing rates and reduce the burden to the NHS and the sufferers. Ed's already mentioned the new document that Legs Matter has just produced. I am the very proud chair of the Legs Matters campaign. And actually, we've written a document about the need for change, the need for changing the culture, the quest of healing. And I urge you all to read this document if possible, because that document really helps you to question your current thinking in terms of what do you believe and how do you need to change in order to improve the outcome for your specific patients. Along with Legs Matters, the National Wound Care Strategy Programme, though, have started to help in terms of the lower limb burden. As you know, the National Wound Care Strategy has been around now for a number of years. It was commissioned by NHS England and NHS Improvement to really think about how we are delivering care for patients, really trying to focus on that evidence-based practice. And the National Wound Care Strategy Programme has 3 clinical arms to it: pressure ulcers, surgical wounds, and a big arm called lower limb ulceration. And the clinical recommendations that's come out from the National Wound Care Strategy are very clear and very welcome. It finally provides us a definition of actually what is a leg ulcer compared to a foot ulcer. We have a clear line in the sand, as you can see on this diagram. It really articulates that we have a window of opportunity to get these patients to heal at the beginning of that journey. And it really brings home in terms of the number of patients that's affected, and that we are currently treating patients with significant volumes with lower limb ulceration. But there is a highlighted variation of practice, and actually what the National Wound Care Strategy says is this national variation actually provides us an opportunity. It provides us an opportunity to actually reduce costs, improve service provision, and therefore reducing the burden on the services, but also improve quality of life for our patients. So the first thing that the National Wound Care Strategy highlights is the need for immediate and necessary care. And when we talk about immediate and necessary care, this is the first point of contact for a patient with a lower limb wound. And it doesn't matter where this patient contacts, if you like, that they should receive this bundle of care right there, right now. So this could be a patient who is presenting at a walk-in centre, an A&E, an urgent treatment centre, onto the district nurse caseload, who's got skin tear within a nursing home, seeing a qualified practitioner, a practice nurse. This is immediate and necessary care, and actually that is commissioned by every NHS service at that point of contact. And the first thing the National Wound Care Strategy says is that we need to assess for red flags. And these red flags really is that immediate concern, that immediate need for escalation. And we've tried to put that in to make sure that every patient is safe. So the red flags are acute infection, acute or chronic limb-threatening ischemia, suspected DVT, or suspected skin cancer. Now, I'm a vascular nurse consultant, and I can recognise those things very easily because it's in my day-to-day clinical practice. But what I think is really important is that you guys out there working in generalist practice are able to recognise those red flags. So I just want to spend a few minutes actually talking about their clinical presentation. So the first red flag is the acute infection on the leg or the foot. So in other words, we're trying to tease out, have they got a cellulitis or even a foot infection, especially a diabetic foot infection? So I'd just like you to remember, what are the clinical signs of infection? So remember that we get those systemic signs, those big signs, those signs of a host response of that bacterial burden. So one of the greatest signs is a fever, so a high temperature. You know, a thermometer is still a very good tool for nursing diagnosis. Another systemic feature can be a tachycardia, an increased pulse, or patients saying that they feel generally unwell, flu-like symptoms, or a general malaise. And then there are local features. So local features of infection include redness with clear demarcated edges. If you look at that typical cellulitis picture on the top of that slide, you can see that there is a clear demarcated regular line between the erythematous, the red tissue, and the healthy tissue. There's so much of a clear line that you can actually draw around it, can't you, with that skin marker. So clear, definitive edges is a good sign of localized infection. Within the limb, the skin can often look like orange peel, so you get that tethered approach, and that happens because actually the subcutaneous tissue starts to swell, but because of where the hair follicles are tethered down to the dermis, you get that swelling and that appearance of that orange peel. Within infection on the leg, it is always painful, and it's much more painful actually on touch. There is often heat, especially of the reddened areas, and that edema can actually result in complete elimination of those wrinkles, so the skin can look very shiny. You can have presence of pus or blistering, and they are signs that you could have a cellulitic type infection. And with a cellulitis infection, actually, that immediate and necessary care needs to be antibiotics straight away with escalation, probably to a local practitioner such as a GP. The worrying thing, though, that we need to be aware of is patients who've got infection on their feet, especially if that patient is a diabetic, because we know that diabetic foot infections, like that bottom picture that you can see, is actually a reason why patients can lose digits or limbs or potentially lives. So if you've got any signs of infection on the foot, the first thing is the patient diabetic? Even if they say to you they are not, do not believe them. Do a test to make sure. Look at the recent HbA1c if it's documented. Maybe do a BM stick or even dipstick the urine. If a patient is diabetic with an infection, that is an urgent medical need. That needs to be escalated within the next hour. Some patients, if you've got significant diabetic foot infection, will need referral on to A&E. Cellulitis can often be treated with primary care with oral antibiotics in the first instance. So that's the first one in terms of infection and foot and the leg. The next one is really thinking about the signs of sepsis. So if you're working with the NHS at the moment, sepsis is now part of our annual mandatory training. It's all over the place. It's thinking about actually those clinical signs of sepsis. So it's really thinking about that elevated temperature, pulse and respiratories, that reported breathlessness or the difficulty bleeding. You can get a rash, but actually that's more of a type of a final stage, if you like. Patients often can look blue around the gills because of the problems in terms of oxygenation. And the patient often reports they feel fevery, cold, really unwell. You can have increased confusion, slurred speech, generally not making sense, feeling very sleepy or difficult to rouse. But many of you out there know the signs of sepsis. We screen our patients on a regular basis for this. So hopefully you don't feel overly worried about diagnosis of infection or in terms of sepsis. One of the red flags, though, that you may not feel overly confident about is actually assessing whether they've got acute or even chronic limb-threatening ischemia. So let's just build those two things down. So acute limb ischemia, I can promise you now, you will not miss. Acute limb ischemia is, oh my gosh, at 5 o'clock tonight, I noticed I had a shocking pain on my foot. The whole of my leg's gone white. It looks mottled. I'm in absolute agony. I'm writhing around on the floor. Actually, if you've got an acute limb ischemia, the place to go is urgent A&E without a problem. So acute limb ischemia, you'll notice. I promise you will notice. But chronic limb-threatening ischemia can be a difficult beast. But actually, chronic limb-threatening ischemia is not a medical emergency. So with chronic limb-threatening ischemia, the first thing is the pain or the ulcer will be on the foot, especially the digits. That is a classic critical chronic limb ischemia lesion on that second toe. You can see that bottom picture, it looks slightly red, does that foot? And that's often we describe as sunset foot and dependent rubor. And that's because you've got maximum vasodilation. So every drop of blood that's getting down to those arteries is trying to be perfused into that surrounding tissue. So therefore you get flushing, just like you do on your cheeks. And the way to diagnose whether that's actually because of arterial flushing or infection is to simply raise the leg up to the level of the hip height. If it disappears, does that redness, you know it's due to vasodilation and flushing. If that redness remains, it'll be due to infection, because it doesn't matter where you put the leg. If it's red due to infection, it will always remain. Patients often report a background of intermittent claudication, so pain in the major muscles of the lower leg during period of exercise and only at exercise. But actually with chronic limb-threatening ischemia, there is no need for an urgent admission. It does require urgent referral to the vascular team and ideally being seen by the vascular team within 48 hours. Because if revascularization doesn't happen, you're going to get further tissue loss. And chronic limb-threatening ischemia can be terribly painful for your patients. The next red flag is actually suspected DVT. And the one thing I would say in terms of who you are suspecting DVT, it is unilateral. one leg swelling. If you've got bilateral leg swelling, don't, lower your heckles, if you like, in terms of DVT. It's very, very unlikely you're going to have bilateral DVT. There is a sudden onset of the edema over the last 12 hours, and patients often report pain on flexing and movement of the ankle. You can get slightly a red or a purple discoloration because of the venous obstruction. It can be warm to touch, and it's often extremely painful if you palpate and put some pressure on the back of the calf because of the venous engorgement. But try to be a little bit Miss Marple if you're suspecting a DVT. Think about what could have been the preceding event. Have they just been on a long-haul flight? Probably not, because of COVID. And in fact, long-haul flights and the link to DVT is diminishing year on year. But do think about a period of immobility. Have you recently been unwell and been in your bed a bit more, or sitting in your chair? Have you recently had a cast on, some type of plaster of Paris? Have we certainly affected your mobility by something else? So be suspicious of your suspected DVT. And then the final red flag is the suspected skin cancer. So you're really thinking about, actually, is this actually a skin cancer rather than a leg ulcer, like these two pictures here? The top one's a basal cell carcinoma and the bottom one's a squamous cell carcinoma. And patients report often having a lump or a bump or a mark that's been changing over time. They can be terribly itchy, tender and painful, and the patients often report it heals, it bleeds, it crusts, it oozes, it gets better, then it comes back again. And I urge you all just to lower your tolerance for a wound biopsy. There are many, many undiagnosed squamous cell carcinomas and basal cell carcinomas out there. But what I would say is, please don't get too het up on the red flags. I want you to be competent and confident in their assessment, hence why we've provided you this information today. But all of those red flags are still relatively rare in clinical practice. I've probably only in my clinical practice seen 5 acute limb ischemias. They're not common ground. So the majority of the patients that you're going to be seeing out there, you're going to be able to quickly tease out, cross off the red flags aren't there. So therefore you can press on with the immediate and necessary care. So what is the immediate and necessary care? What do you need to be doing once you assess those patients for those red flags? Well, the National Wound Care Strategy are quite clear. The immediate and necessary care should include wound cleansing of the surrounding skin, and application of emollient. Yes, cleansing is back, and hallelujah for that. They do say that you should apply a simple low adherent dressing, but one with sufficient absorbency. And then the National Wound Care Strategy is saying something rather tremendous, if you ask me. They're saying if the wound is on the leg, not the foot, but on the leg, so you remember that line in the sand of just above the malleolus? If the wound is on the leg, you should apply first line mild graduated compression of less than 20 milligrams of mercury, without an ABPI, without a foot pulse palpation, but that's it. So long as you've teased out the red flags, assessed for them, it's 20 milligrams of mercury here and now. Because when the National Wound Care Strategy looked at the risks and benefits of this, we really thought that actually that mild degree of compression is going to actually provide huge benefits for the patients. Once you've teased out those red flags, that level of compression can be used perfectly safely in these patients. So when we talk about this mild graduated compression of less than 20 millimeters of mercury, what do we mean? Well, there's a number of ways that you can apply that. You can actually use reduced compression bandaging, but actually to apply a compression bandage, you need a degree of competence of being able to do that. So I don't think that's overly accessible to everybody. You can use a compression wrap device, but there's only 1 or 2 of them on the market that you're actually able to measure the degree of pressure that they provide. And actually the compression wrap system is a very expensive way of applying that first aid compression. Tubi grip should not be used in any form because it provides a cylindrical compression rather than the graduated compression, so falls outside of that National Wound Care Strategy recommendation. So actually a really good, quick and easy way to get that 20 millimetres of mercury pressure on is a British Standard Class 1 stocking. Easy to measure, easy to apply, quite uniform, and provides that beautiful graduated compression that we need in that first aid treatment. And the reason why this is so important is that actually, if you've got any form of wound on your leg, there will be a challenge within the capillary bed. So remember that the arteries and the veins are connected by that capillary bed where the gaseous exchange takes place. And if you look at that capillary bed in more detail, you can see that the green within that diagram is the lymphatics that's threaded through. So when you have any patient with any injury, you've got an internal inflammatory response, which will increase the amount of lymphatic response, so therefore more likely to get edema. If you've got any underlying venous disease, that will actually pressurize that capillary bed, forcing those blood products into the surrounding tissue. And all of this can be really benefited from compression. It helps to reduce the internal inflammation that's caused the wound in the first place. Compression therapy is a hugely potent therapy. It has got proven anti-inflammatory mechanisms. And I'm not just talking about on the wound bed, I'm talking actually about in the tissue below that wound. We know that if you've got venous incompetence and edema, actually that'll reduce the tissue perfusion. So if you can reduce the venous incompetence and reduce the edema, you'll have an increased blood supply. We know that if you've got venous hypertension, such as varicose veins, it will start to affect the perfusion pressure and therefore those cells' ability to get the nutrients and the oxygen that they need. So compression helps all of this. And actually, many of you may be fearful or been taught in the past, be careful with your compression, it's a harmful thing if you get it wrong. Actually, I'd like you to reduce your heckles, if you like, with compression therapy. We've gone too far with the be careful. We have numerous studies now to say that we can use, under the right hands, 40 millimetres of mercury pressure very safely in ABPIs as low as 0.5. So within vascular fraternities, we're no longer so obsessed in terms of the level of compression in our ABPI. And I urge you all just to think about the benefits of compression in terms of that capillary bed and how it helps the oxygenation, the nutrients, and the reduction of that internal inflammation in your patients. So after the immediate and necessary care that we've spoken about already, the National Wound Care Strategy sends us some really strong targets. And it says that we should be performing a holistic assessment, including the ABPI as part of that assessment, within 2 weeks of wounding. I know that many of you out there will be thinking, good grief, that's a huge challenge, it's an impossible mountain to climb. Can I just say, in my organisation, we are meeting that target without any problems whatsoever. It's simply because we have a different approach. We are focusing on the new wounds that's coming onto our books to make sure we do that timely assessment within that 2-week time frame. And actually, what we've done across our district is actually really think about an evidence-based approach to venous leg ulceration. And many of you will remember that quite a while ago now, believe it or not, and myself and Joy Tickle wrote the Leg Ulcer Pathway. And we have simply adapted that to in line with what the National Wound Care Strategy is telling us. And truthfully, we've made very little changes to that pathway. And the reason why we've had to make very little changes is that was always an evidence-based pathway. It was always there in terms of where to use the compression, at what point and what type of compression. And the National Wound Care Strategy is only appraised and critiqued the evidence and therefore saying the same thing. I think what the leg ulcer treatment pathway though does is provide a very clear flow chart, if you like, to help clinicians out there in choosing the right compression at the right time, especially trying to implement that supported self-management that can be very, very valuable in terms of lower limb wound care. So The treatment for a venous leg ulcer is that evidence-based approach, and the National Wound Care Strategy spells this out very clearly. And all we've done really is make sure that that's in a nice, simple flow chart. This is available free as a resource through L&R for you. I urge you all to copy it, do what you like with it. We've published it for you to use, you to share, you to change, make it local, but actually make sure we continue to deliver that evidence-based approach, as well as that target of that 14-day assessment. Because the National Wound Care Strategy, just like the leg ulcer pathway, actually believes that compression hosiery kits are as good as multi-layer compression bandaging, but they actually provide some advantage in terms of patients are able to self-care. Patients are able to take them off so they can bath and shower as they like. It doesn't restrict their access to footwear or what clothes that they use. And we really need to be thinking about using those, because we all admit that at times we need compression bandaging, and often we need that to reshape the most congested of legs, or we need it actually to help the exudate management because the dressing's just not absorbent enough. But the evidence is telling us as soon as we can, we should really be trying to step that patient down to using compression hosiery as soon as we can within that journey. And I'm talking about compression hosiery of 40 millimeters of mercury, the key in terms of pressure to heal a venous leg ulcer. And the reason why we need to do this is that actually we need to brain train that patient the importance of compression on a long-term basis, because this is key in terms of preventing that recurrence. It rather frustrates me that within clinical practice, we can spend many, many weeks helping these patients to heal. But actually, once we've got them healed, we tend to just prescribe some stockings, hand the stockings over, and we've gone. I find that that's a really bad approach to prevention of recurrence. We actually need to be still there with that patient to make sure that that stocking is the right one for the patient, both in terms of their application and their therapeutic response to that compression. So by stepping a patient down while they've still got a wound into a compression hosiery kit, you can be there really to problem solve some of the issues. Maybe we simply just need to prescribe them some type of donning or doffing device. Maybe we need a different type of stocking that's going to be easier to put back on. Maybe the compression hosiery is actually allowing the edema to recur back inside, so we need a stronger, stiffer fabric to keep that compression. So we really need to focus on working with our patients, because if we get the long-term compression, that's how we make a key in terms of the prevention of the recurrence. And remember that 69% of patients recur within 12 months. By working with your patients to make sure they've got the right compression that's good for them and that's therapeutic for the leg is your best way in terms of that prevention of that recurrence. We also know that that recurrence really impacts on a patient's quality of life. Imagine being that patient that's had that compression therapy and seen that painful wound slowly get better and heal, only for it to recur in the next few weeks. Imagine how distressed that patient must be of, oh my God, it's back again. We also cannot forget the financial impact of this in terms of the cost to the NHS directly from the cost of you as the clinician and the products. So actually, we really need to be thinking of trying patients with the right hosiery. The first one that you give them probably isn't going to be the right one in terms of compression hosiery, but it's still cost effective to keep swapping and trying until you get the right hosiery for this patient so they can wear this on a long-term basis. Because actually we need to make your life better, because a lot of the clinical workforce at this moment in time is spent actually treating these active venous leg ulcers. And we really know the burden that you're under in terms of the hours of work, the number of visits, the number of appointments that you're seeing. And we really need to think about getting these patients healed as quick as possible and keeping them healed as long as possible. And therefore the recurrence has to come as being an important step, just like the treatment and just like the immediate and necessary care. Please, please be an enthusiastic leg ulcer clinician. Please don't let your morale with leg ulceration start to become diminished. The treatment of patients with leg ulceration is one of the most rewarding things that you can do. If you get this right first time, you can heal these patients very quickly indeed, and actually you can keep them healed. And there's nothing more powerful than a nurse than the thank you from a patient. It's what makes our heart beat on a daily basis. So following that healing of that venous leg ulcer, we need to make sure we've got the right compression for the patient that's being therapeutic on the leg. It's about actually keeping them under your care, ensuring that they've got that 6-monthly review and replacement of that compression garment. Patients really should never be discharged. We should constantly keep them. I'm not saying that these need a band 6 or a band 7 nurse, but they certainly should be under the care of maybe a very experienced healthcare assistant, and certainly have access back to nursing services easy, so patients can self-refer if they have any evidence of recurrence or any problems with our compression hosiery. We need to ensure that we're completing that holistic assessment to make sure that that compression hosiery is fit for purpose. Many people think that compliance with a patient is a real challenge with venous leg ulceration. I challenge you against that. Actually, it's about finding the right fit for the patient. There is many, many options out there. You all buy your tights from different shops. It's just about finding the right pair of tights or the right compression hosiery for your patients. So, you know, we need to ensure that the recurrence is there. And I'm really pleased to work with L&R because actually the focus on every aspect of the care of the patient. We need to be talking more about just the compression, but we need to be thinking about actually the level of activity, the nutrition, the hydration, the elevation, the smoking cessation, the weight control, because these are all key to keeping our patients healthy and well. We invest a lot of time in terms of our education, but how much education do we give our patients? The power of a patient information leaflet, some supportive material is very, very powerful. We need to ensure our patients have got the right advice at the right time. And there is some great information available from L&R. They have a whole package of resources that is designed simply to support you in every step of that way, especially of that prevention of recurrence. So I'd just like to share with you, if it's okay, just a quick video in terms of what is available through L&R in terms of helping support your practice. So hopefully that really showed the depth and the breadth of the support that's available through L&R for you. And again, there is a fantastic thing called the Squeezed In Club. And as you can see, it's supported by Johnny Vegas, who's one of my favourite comedians. So, you know, if he's prepared to get behind this, it just tells you the power of it. In fact, within the Squeezed In Club, Johnny Vegas reports of a personal challenge of one of his family members having a venous leg ulcer and the impact they did with his family and himself. It's a really potent story in terms of the impact to the patient and their family. So I urge you all to have a read of that. But the Squeezed In Club really helps to empower people to really manage their own health, their own leg health. And it really helps in terms of releasing some of the time back that you desperately need, the time to care for your patients. So, you know, I urge you and encourage your patients to actually look at the resources and sign up for the Squeezed In campaign. So I'd just like to leave you with a few key take-home questions, really. ones that I'd like you to reflect on to really think about the level of care that you personally provide and your service provides. So, do you follow evidence-based pathways to inform your lower limb ulcer management? Can you question your colleagues and system processes in terms of what is the approach to early identification in your trust? Do you actually have an approach? Can you implement the immediate and necessary care? Do you currently apply that 20 milligrams of mercury pressure for all lower limb wounds in the absence of the red flags, whilst you're in that holding position of getting that holistic assessment? If not, why not? Do you apply all the other aspects of that immediate care? Are you cleansing your wounds, emoliating? Are you using dressings with the right amount of absorbency? If not, what's stopping you from doing so? And do you ensure that all your patients know the need to reduce their own risk of recurrence and how they can take some responsibility for their own well-being? I hope at the end of this session that what I give you is actually a little bit of information, a little bit of education, a little bit of confidence to be able to actually change your own practice. And actually, what we'd like to do this evening is actually for you to make a pledge. I believe that if every one of us just did one thing different tomorrow, I think the world is a better place. So I'd like you to make a pledge, and you can do that by entering it in the comments box if you can. And I really want you to really make a pledge of what you personally can do to support that early intervention and that better long-term outcomes of your patients. What's the one thing that you're going to take away today that you're going to start to implement in clinical practice tomorrow? So please, please make that pledge. Let's really start to transform patients' lives. Thank you very much for listening. And hopefully we've got some questions that we're able to answer.
Yeah, and we've got so many questions. We've had so many comments. We've had so many questions. Leanne, I thought that was brilliant, but also a massive thank you to our audience. You've joined us in your hundreds from all over the UK, in fact, all over the world. And thank you for getting involved. So, Leanne, if you don't mind, can we crack on with the questions? Because we've got quite a few.
Absolutely.
So, question one, Kerry. Thank you very much, Kerry. Do you think we should be thinking about more specialist lower limb services in the community, or educating all staff in the community?
Oh, Kerry, this is a really difficult one, because truthfully, I could argue black and then back white again. And actually, if you'd asked me the question a decade ago, I'd probably give you a different answer to what I give you today. I would love a world where every single person is fully up to speed with leg ulcer assessment. That's my ideal world. I'd like every clinician out there to be able to do this. And I think things like the leg ulcer treatment pathways help make it a generic. But the more I realise that we have a transitional workforce and that we have problems in terms of recruitment, retention, education, and getting you up to that standard, the more I'm teased towards, do we need actually just specific people to do this? Gone are the days when we had great matriarchal district nurses that knew everything that you could refer to within your own localities. I think certainly referring it all to specialist nurses is not the way forward. I think that all we'll do is backlog patients to waiting to get to us, and I don't think people need a specialist nurse. But I think what we should be doing is really thinking about like leg ulcer champions out in community. So you've got an increased confidence. And when I talk about that, I mean somebody that's prepared to go, I can't get an ABPI, but you know what, that patient still needs some compression. And actually, those skills can be really easy to learn if you've got the right mentor around you. So I suppose I'll go the middle ground. I think that what we need is everybody to be involved, but I think that we need a level of champions to be able to really install this best practice across the UK.
Yeah, great answer. Probably an impossible answer, but a great one nonetheless. So question 2, is a British standard class 1 okay for a patient to wear if they have swelling in the limb?
Okay, so it depends on what degree of swelling, let's say. So remember, this is emergent, immediate and necessary care. So this is only a holding place. for you know, a 2-week period. Is it going to control edema? No, it's probably not. But actually, so long as you've got mild to moderate edema, it's okay as a holding place. If you've got a patient with significant amount of edema, we need greater squeeze on them. So actually what we need to be focusing on that patient is not here and now, is actually getting that timeline to that assessment as quick as possible. Because you're already recognising by that question it's not good enough. Because if you've got any form of significant mild to moderate to severe limb swelling, that patient's going to need a higher degree of compression to be therapeutic. So I'd say, yes, actually, British Class 1's okay, but only as a holding position. As soon as you can, you need that patient to be fully assessed and get them into some appropriate strength of compression that's actually going to be able to control or eliminate that edema. And yes, that is much better done by using European classification of stockings, let's call them, with a stiffer fabric that's actually designed not to allow that limb to swell. But remember, the 20 milligrams of mercury is a holding position. So it is a way forward to hold. I'd still be saying if you've got really large limb volumes, I might be using some form of compression bandage to hold them. But if you can't apply compression bandaging because you haven't got the skills or the competence to do that, it's still a half okay holding position. But get your full assessment done as soon as physically possible.
Brilliant, thank you, Leanne. Question 3 from Johannes. Are there any easier ways of identifying red flags on darker skin?
Oh, now this is really interesting. So I might just mention a competitor of something else that's coming out. So please watch out for a new best practice statement that's going to be done about actually how we assess patients with differing skin pigmentation. So there's a couple of things within that. Erythema is questionably more difficult to see on darker pigmented skin, but I promise you can see it. Venous hypertension again and venous staining is difficult to see, but you can see it. And then we have got some great clinical images that's going to go into that best practice statement to reinforce that. So it's much more challenging the deeper or darker the pigmented skin, but there are still some clinical signs. I think it's a huge challenge. You look at any textbooks that's out there, it's 99.9% clinical images on white skin. The world is not like that. We really need to be calling out, actually making our textbooks, our resources fit for practice across every type of different patient that we see in today's NHS. So it is a challenge. I recognise it. Some people can argue you should be using the term red legs when actually you might not see it. But I still believe you can see a red discoloration within patients with the darkest of skin tones. It's a challenge, but it's one that we really need to be thinking about. It's the same as a non-blanching erythema. There's a whole debate going on whether you can see that in a pressure ulcer or patient at risk of pressure ulceration in the darker skin tones. But it's a great question, and it just proves really how at times the NHS isn't fit for purpose in terms of, you know, I've only shown you pictures on white skin tonight. You know, it is something we need to get better at.
Thank you. So question 4 from Claire. Thank you, Claire. Would you need to do a Doppler before applying the compression?
Not the 20 milligrams, not the 20 millimeters of mercury. All you need to do is assess for those red flags that you now have the skills to do. If you're feeling still unsure, have a word with any clinician. They'll help you how to actually build your confidence in assessing those red flags. Any GP can assess for them, any primary healthcare practitioner can assess for those. So build up your confidence with those. Once you've ticked off the red flags, if the wound is on the leg, you can put on 20 millimeters of mercury pressure, straight here, straight now. You only need that ankle brachial pressure index or another form of vascular assessment to put on the 40, the full therapeutic strength. So I think that what the new wound care strategy does is actually provide some permission, because I know many community practitioners out there are completely frustrated because they recognise it's a venous leg ulcer, they recognise the need to get some compression on, but they haven't got a Doppler, they can't get an ABPI, they refer it on, and it's a 6-week time frame for that tissue viability nurse to see it. This provides you something to do here and now. This provides you at least a decent holding position until somebody can complete that assessment for you.
Thank you. So question 5 from Andrea. Should mild compression be used if the patient has a foot ulcer as well as a leg ulcer, or only applies to the leg ulcer?
Okay, so this is where it becomes a little bit Miss Marpley. Okay, so to me, if you have a leg ulcer and an edematous leg, I don't really care if you've got an ulcer on your foot as well. It's telling you need some compression on it. If you've only got a wound on your foot, I would be more cautious with that. I'd still argue if there's some edema on it, you're going to need some compression at some time. But actually, if you've got a wound on your foot in isolation, they're the ones I would be thinking, let's just double check your arterial supply before we move on, because that's much more likely to be an arterial wound. You can still get venous leg ulcers on the dorsum of your foot, but they're not as common. So it's about really using your clinical signs to say if you've got a wound on your leg as well as one on the dorsum of your foot with a leg that's edematous, and the patient's not reporting any signs of red flags, especially the pain in the foot, the dependent rubor, the constant pain in terms of arterial rest pain, or that background of intermittent claudication, and yeah, you can safely use that 20 milligrams of mercury pressure.
Brilliant, thank you. So question 6 from Becky. Thank you, Becky. What about heart failure patients and compression? Could it cause fluid overload? And what and when would you advise application for these patients?
Oh, what a good question, Becca. And I must say, this is the one thing that frustrates me the most in today's world. Okay. Compression therapy is a often required treatment for heart failure. And I say that because heart failure patients by default will get lower limb swelling, and then they'll get blistering, then they'll get weeping, and then they'll develop ulceration. Those patients are crying out for compression. There's 2 different types of heart failure patients, though, that I just want you to remember. There's an acute heart failure patient. They're admitted to hospital, they're on IV furosemide, they are unwell. Are we going to put that patient into compression and actually force some of that into their circulatory volume? No, we're not, because there's a potential of overloading that patient. But if the patient is out in community, like 99% of the congestive cardiac failure patients that there are, and they're on normal doses of therapeutic diuretics, then yes, that patient needs compression. Even if that patient is having an exacerbation of their heart failure, if they have got weeping of their lower legs, they need a degree of compression. We would never recommend full strength 40 milligrams of mercury to both legs simultaneously, but we would recommend a staged approach. Slight squeeze on one, slight squeeze on the other, build up to 40, build up to 40. I'd say wherever possible, work in combination with your heart failure nurses. But I say that with a degree of caution, because instantly some heart failure nurses will go, that'll overload them. And there is a real need for education in the heart failure nurses about the use of compression and the need for compression. And even in my organisation, we had a battle only 2 weeks ago that we had a fantastic patient with bilateral lower leg swelling, huge amounts of leakage. We got them into compression. They did really, really well. He had an exacerbation of his heart failure, still out in community. The heart failure nurse stopped his compression. His legs got bigger. He got admitted because bilateral weeping of his lower legs, and he ended up an inpatient with us. So we really need that joint conversation. There's some great information about using compression in congestive cardiac failure produced by the British Lymphology Society. So I'd urge you all to have a read of that. It helps to support your practice.
Yeah, and I love your passion. If there are not loads of leg ulcer champions at the end of this, then we should be shot. So there's 5 more minutes left. There's 2 more questions. So question 7 from Hannah. For healed ulcers, which level of compression for maintenance of their venous disease is required? Does it need to be the full 40 milligrams?
So it needs to be what is therapeutically effective. So there's two things that you're talking about in terms of your prevention of recurrence. Number one is prevention of edema. That's slightly easier because actually, if you are using a lesser value of compression and the edema is coming back, you need a higher, stronger value of compression. In terms of your venous disease, if you've got return of venous eczema, it's telling you need a greater amount of compression. The evidence tells us that we should be trying to put patients into class 3 stockings for prevention of recurrence. I can all hear you screaming at me going, class 3? Good God, nobody will get them on. It's about finding the right amount of compression that the patient can apply that's still therapeutically effective. So for actually me, many of my patients, I actually don't downgrade them from a compression hosiery kit, give them 40. I actually keep them in that, especially if it's the second time ulceration. And I do that because I'm able to provide 40 millimeters of mercury, but actually using a 2 combination. So it's dead easy for the patients to get on and get off again. So don't worry about having to step down. Actually, I would say try to keep your patient in the highest level of compression that that patient will tolerate. If you have stepped a patient down, watch that patient. Don't discharge them just yet. Make that review in a few weeks. Look for rebounding venous eczema, skin changes. Look for increasing amount of edema. If you've got either of those two things, it's a clinical sign you need to increase the level of your compression. And final call, just remember that venous hypertension can be treated by venous intervention. So compression only palliates it by squeezing the leg. Remember, if you've got a patient with ulceration, we should actually be scanning their superficial venous system to see if there is any intervention that we can do, day case, walk in, walk out, local procedure, to actually turn down the tap on the venous pressure. That really helps to heal patients quicker, and it reduces the risk of recurrence by about 2/3.
Thank you. So last question from Andy. Thank you, Andy. How do we make 20 mm of mercury compression available at first contact in the community?
Now, this is a challenge, and I would urge you all to really think about, and this is one of your take-home homework messages. I think it really depends on where you are, where you're working, what's your skill set. So how would we do it within a vascular team? Well, we put on compression bandaging because it's one box, we pull it off and we're good at putting that in, and it's quite versatile. But actually, if you are in an urgent treatment centre, you're never going to get all of your nurses to be able to be competent at applying that compression bandage because it's a skill in itself. So you need another thing to be able to pull off the shelf. And for me, that's where I'd use class 1 British hosiery. So I think it's about you thinking about where are you? Have you got the shelf space? What's your skill level like? And what's the easiest tick box for you in your clinical practice? There's many solutions out there to deliver that 20. You've just got to find the right one for you.
Leanne, thank you. And thank you for the whole event. You've been absolutely brilliant. Some incredible comments, very kind comments have come through. So if you get a chance.
Absolute pleasure. And I love doing this. And, you know, healthcare professionals get such a bad rating. Nurses sometimes can feel so undervalued. Listen, we've got the best job in the world. Don't ever forget that. You know, what you do for your patients is amazing. You've got the ability to touch a patient's heart like nobody else can. For that, we should be very proud.
Well, it's that kind of passion that inspires people involved in education like me and my team to do what we do. And, you know, I'll go home inspired tonight. But do have a look at the comments. There's some fantastic stuff there. Ladies and gentlemen, thank you so much for your engagement throughout. Hundreds of comments and hundreds of questions. So thank you very much. The attendance certificate link is now available for download. So please do that because that counts towards your revalidation and can go into your portfolio. We do loads more events like this online. So please visit our website, which is woundcare-today.com. And do come to our live event in October. It's like, I'm so excited. It's been too long since we've been in a room together. So that's the 19th, 20th of October. That concludes tonight's event. So thank you, Leanne, thank you. Again, just hugely appreciated from me and the team. A massive thank you to Lohman Rauscher for not just this event, but supporting so many levels of education, not just across our business here, but across the whole marketplace. To the Wound Care Today team and Mole Digital team, you know who you are. I'm well aware how much work goes into these events. So a massive thank you from me. And last but not least, to our audience, your commitment to attend these events staggers me. Please stay safe, stay strong, and I look forward to seeing you soon, if not at Milton Keynes. Take care and have a lovely evening. Good night.